I'm Sita Fay, Director of External Affairs.
I'm Jamie Buck, Director of Innovation.
This is Fundamental, the podcast from NYSIF, the organization at the intersection of finance, health, business, and labor in New York. I'm so excited to welcome today Dr. Trinh, cardiac anesthesiologist for more than a decade. Dr. Trinh has seen firsthand how treating patients in the operating room can increase a hospital's carbon footprint. As medical director of sustainability, she's led efforts to reduce the most harmful anesthetic gases. Under Dr. Trinh's leadership, Mount Sinai Health System recently received multiple Practice Green Health Environmental Excellence Awards, which recognize healthcare institutions that have demonstrated leadership in environmental sustainability. Practice Green Health ranked Mount Sinai among the top 20% of U.S. hospitals, leading the way to environmental stewardship. Dr. Trinh, welcome to Fundamental here at NYSIF. We're so excited to have you here. Dr. Trinh has been a partner with us. We're going to spend a lot of time talking about insurance as a catalyst for climate action, our climate action premium credit program for the healthcare sector, and Dr. Trinh's leadership. Dr. Trinh, welcome.
Thank you so much for having me. It's a pleasure to be here, and I'm looking forward to a really good session.
We're very much looking forward to this discussion. Dr. Trinh, thanks for joining us here today. You're the first medical director of sustainability at Mount Sinai. What's that mean?
So it's very exciting for us. I'll tell you that when I started out, it started out as an interest and a passion of mine, but I don't think I really had an idea where this was going to lead me or that it was going to end up being a career pathway for me. I started off meeting people who were interested and passionate about sustainability, and that's how I started. We worked on several initiatives together, and over time, we were able to develop a case for becoming the medical director. So to me, personally, becoming the medical director of sustainability means that I'm able to step into this new role to integrate sustainability into our clinical care, our clinical practice, and operationally at the system level. In terms of the health system, I think what it means is our executive leadership sees the connection between human health and planetary health, and that they value sustainability as a priority, and that they're going to be accountable, and they want to protect human health through environmental responsibility. And I think in my role as the medical director, I would like to integrate sustainability into the fabric of our health system so that it's just not a standalone consideration or an add-on.
So, Dr. Trinh, we were scrolling on social media at Mount Sinai, and I saw some photographs about the Employee Green Team. I'm very impressed with the shirts, but what I want to hear about, what's the substance behind the Employee Green Team? What is the Employee Green Team at Mount Sinai?
The Employee Green Team is basically a network of our employees, and they compose of researchers, clinicians, administrators, people in facilities, and more, who are interested in sustainability and in working and collaborating together on sustainability initiatives. So we believe that it's not just in order to have a successful program, it's not about just a top-down approach. I think sustainability started out as a grassroots approach, especially at Mount Sinai. And so, as you know, Mount Sinai our health system is pretty extensive, and we serve all 5 boroughs. We have the Icahn School of Medicine. We have the Phillips School of Nursing. We also have research facilities as well as outpatient centers and ambulatory centers. So these are a lot of very different facilities with different needs. So the employees from all of these locations are able to come together and work and present issues or things that they want to work on with the Green Team, and we support those initiatives and efforts so that they can work locally on sustainability projects. And so we really see the Green Team and the Green Team members as our sustainability champions that work locally.
Can you share an example of one of the issues the Green Team has brought forward that you're working on currently, or a past issue that you solved?
Sure, absolutely. So the one comes to mind right now. So one of our members brought up that we have a warehouse with a lot of medical equipment, including gurneys, examination tables, drawers, and chests, chairs. And so what we decided to do with this is try to create a virtual marketplace so that it can be shared with other facilities. And so if you are working in an outpatient center, for instance, and you need an examination table, perhaps you can go on this website and request for it. And so that's one of the projects the Green Team is currently working on. Another question that came up and request, we have an employee that works in Long Island, and that person is looking to carpool. So we're trying to figure out how we can create a carpooling network with the Green Team. So we're actively working on that. So those are some examples of the things that we've been working on.
What are some of the inherent challenges, right? So you have employees in all 5 boroughs, and the Green Team is bringing forward. There's no way that one size fits all. So how is all of that bubbling up through the Green Team, and how are you able to support them in their efforts? What's working really well?
I completely agree with you on that. And that's part of the reason why we have the Green Team, because it's not one size fits all. So some things that may work at the East Campus will not work at the Queens Campus. And so the way we try to support that is sometimes we have smaller group meetings and we create working groups at each of the campus if a project comes up, and then they can collaborate and work together. We come together when they come up with issues or barriers, and we try to work on those barriers.
So, Dr. Trinh, you have such a unique and interesting background to bring into this discussion and dialogue here as a practicing clinician and anesthesiologist. Curious to know, was there a particular aha moment for you as a clinician that led you to start thinking about climate change differently? Maybe you could step us through a little bit of that.
So as you know, I'm a cardiothoracic anesthesiologist, so I take care of some of the sickest patients and I take them through some of the most complex cases in the hospital. The reason why I say that is I want to contextualize this. We go through a lot of medical equipment and a lot of resources to take a patient through a coronary bypass case, for instance, or a cardiopulmonary bypass case. I remember this day very vividly. I came into the operating room and the patient hadn't even come into the OR yet. And in the corner of the room, this is a perfectly clean room that we've prepared. There are already 3 30-gallon bags that were tied up with trash. And this trash was actually wrapping material and all the equipment that we needed to prepare for the case. And that's before the case even started. It was the sheer amount of waste that we had in the operating room. It made it very clear to me the amount of resources we use and the fact that we would probably have a significant environmental impact. Now, we do 1,600 bypass cases a year. So multiply that case times 1,600. And so it's hard not to take action when you see something like that. And that was my big aha moment, I would say. And that's when I became more involved.
The magnitude of that is, you made that very clear in that example.
Dr. Trinh, Mount Sinai is a NYSIF policyholder and has signed the pledge. We talk about climate action premium credit program for the healthcare sector. A lot of this goes back to the research that NYSIF did when we were looking at claims, we were looking at heat, we were thinking about what can NYSIF do in this public policy sector. And through the research, we were also learning about how can we help our policyholders with hospitals, in particular in the healthcare system, having such huge contribution to climate change and greenhouse gas emissions. NYSIF really took it upon themselves to think about what could we do as an incentive program. With that, we designed this pledge for hospitals to take, and Mount Sinai was one of the first ones to say, yes, we're going to do it. Can you talk to us about how you're leveraging the pledge to do more? How has NYSIF's program influenced your efforts at Mount Sinai? Because you were doing some of this work already at Mount Sinai. How did the NYSIF program align with Mount Sinai's vision?
The NYSIF Climate Action Program, or pledge, was actually one of the most impactful pledges Sinai has signed on to. And that's because it tied together a financial incentive with climate action. And what this connection did is it aligned our sustainability goals with our operational and financial priorities.
Talk about how you leveraged the pledge to achieve more at Mount Sinai.
I'm going to start off actually with just giving the background of the pledge, and then we're going to go through the components and how we've been able to use the components to further our sustainability program. So just a broader overview. So NYSIF provides a 5% premium credit on workers' compensation insurance up to $1 million to organizations that commit to decarbonization goals and in conducting a full inventory of their greenhouse gases, as well as developing a climate action plan. So first and foremost, by requiring the full comprehensive inventory of carbon emission, what that did for us is that it allowed us to see where our carbon emissions were coming from. So in healthcare, we really classify emissions into 3 big categories or scopes. So Scope 1 emissions comes from the facility itself. Scope 2 emissions is usually from purchase of energy, heating, cooling. And Scope 3 emissions, which is the third category, is pretty much everything else. And so these are greenhouse gas emissions that come from supply chain, pharmaceuticals, food, our medical devices, construction work. So that's the big bucket. So by creating a full inventory, now we can identify areas where we have higher emissions, areas that we can target for reduction. So that in itself is incredibly powerful. The other part of it is the fact that not only do we know where our emissions are coming from, we now have a baseline. So that means that when we reduce our emissions, we have something to compare this against. The next component that is actually incredibly important is actually creating the climate action plan. That in itself creates a roadmap for us for decarbonization. So it allows us to look at our program, look at short-term projects, long-term projects along the way, and try to reduce our emissions from all of that. The other thing that's great about the NYSIF program is the fact that we have to report on our progress annually, and it allows us to be iterative. So we can go back and we can see how we've done in the past year and modify our strategy if need be. And the other part of the pledge that is really important is the fact that you guys are giving us, or not necessarily giving us, but the rebate of $1 million. The spirit of that money is that we can reinvest it in sustainability, in our infrastructure, in our initiatives to decarbonize. And I think that's really important and powerful. So the NYSIF pledge has been truly transformative for us because it's allowed us to engage with our leadership, with our clinicians, and our suppliers in a very meaningful way. So I think that the NYSIF pledge is actually an excellent example of how insurers and health systems can partner and actually accelerate environmental health and climate leadership.
We were recently at the Clean Med Conference in Atlanta, and that's put on together by Practice Green Health. And I was among so many different clinicians, and this is different for us, right? We're in the insurance industry, workers' compensation, disability, PFL, government entity. We have all of these overlapping cases, but I'm not a clinician. And I was so taken by how many clinicians were in that room. But clinicians are talking to clinicians, which is important. How do you take clinicians on one side of the house and get administration inside your hospitals and get everybody and executive on board? I heard story after story about so many grassroots efforts, but these grassroots efforts are clearly being led by clinicians inside of these organizations. And now you have your green team. When you were first having this conversation with yourself or inside of Mount Sinai, did you even see from day one to where you are today? Walk us through that.
Absolutely. So like I said before, this started as an interest for me and a passion. I did not have a clear idea of where I was going to be. And I think at that time, Mount Sinai Sustainability Program was actually just starting, and it was very early in the process. When we started out, it was just grassroots efforts and initiatives. I will tell you that my first initiative was starting perioperative recycling in the OR after my aha moment. And I chuckle about it now because I recognize that it's not the most impactful thing we can do in terms of deferring waste from our health system. But that was my first project. And so what we've done is we've shown success with smaller initiatives, and then we were able to bring it to our executive leadership and try to make a case for the benefits of having a sustainability team, of having leadership in sustainability.
Perfect. Thank you. Dr. Trinh, you talked about in a previous response, you used the word the connection, right? Mount Sinai and the connection between sustainability and financial priorities. Can you talk a little bit about healthcare and climate change connection for you and what that means personally and professionally?
Let me start off by saying that in healthcare, we are responsible for taking care of patients and taking care of people who are affected by climate change. But in the process, we actually are contributing to the overall problem. because we are emitters of greenhouse gases. So the U.S. healthcare sector emits approximately 550 million metric tons of greenhouse gases annually, which is about 8.5% of total U.S. greenhouse gas emission. That's a pretty big chunk. To put this into perspective, that's the amount that comes out or is emitted annually by the entire UK. So it's a big chunk. Within healthcare, hospitals contribute significantly to U.S. healthcare sector's emission. And that's because hospitals are always operational. We're always admitting patients through the ED, and we're running 24/7 basically. Hospitals don't actually ever turn off. We use a tremendous amount of natural resources, a tremendous amount of electricity and energy. And we also generate a ton of waste.
An inherent challenge is to say that a hospital is a huge contributor to greenhouse gas emissions, but why? You've just helped us understand the hospital's on 24/7. The emissions produced indirectly, supply chain, purchased energy, anesthetics, pharmaceuticals, food, single-use plastic, and surgical supplies. When you're painting the picture about what you see before the patient has even crossed the threshold, that helps other people understand what's actually going on with waste. And this isn't unique to Mount Sinai. This is a problem across the healthcare system, which is why NYSIF and our policyholders are really taking collective action together to make this change. It's because of the grassroots effort and what we understand between the climate and healthcare connection.
As a physician and a healthcare professional, what that means to me is that when I'm taking care of a patient, it's not just about the patient that's in front of me. Yes, I want to provide excellent care to this patient, but I also need to be considering the bigger picture and the long-term effects and the long-term consequences and environmental impact that will affect a bigger population and future generations. So as an anesthesiologist, I come in every day, and one of my jobs is to keep patients anesthetized. And one of the things I do is I turn on an anesthetic gas, and that gas is a greenhouse gas that directly contributes to climate change. And so for me, it is knowing this, being cognizant of this. And if all things are equal, all things being equal, if there's a medication that has a lower carbon footprint, I should be choosing that, and I should be thoughtful about my anesthetic and how I provide care. In terms of a personal reason, I think we've been hearing a lot about climate anxiety from the younger population. And this is true even for my daughter, who's 11. They are hearing about rising sea levels, wildfires, natural disasters. And for them, they're not really sure what the future is going to look like. And this anxiety is commonplace, and it's real, and it's valid. And I think one of the things that's important to us is that we do something about it, that we take action when we can, and that we do our part to decarbonize when we are able to.
You're a researcher and an author. Recently, you co-authored on anesthetic greenhouse gases. You analyzed the emissions generated during the treatment of some 53,000 anesthesiology patients. It's a complex study, but could you break down what the findings were?
I'm going to take a step back and talk a little bit more broadly and bring up our listeners to speed in case they are not familiar with what we do. So all of our anesthetic gases that we use to anesthetize our patients for general anesthesia are all potent greenhouse gases. What that means is that they differ in their heat trapping abilities. So the 4 medications that we typically use are desflurane, isoflurane, sevoflurane, and nitrous oxide.
For non-clinicians, that's all of the rest of us. Can you break down anesthetic gases?
All anesthetic gases that we use to keep patients anesthetized for procedures or asleep is what people think are potent greenhouse gases. They all differ in their ability to trap heat, which is what we call global warming potential. Patients typically breathe this in and they exhale it. When they exhale it, it goes into what's called the waste anesthesia gas scavenging system. Less than 5% of it is actually metabolized by the patient. The remainder goes into the WAG system, and that gets released into the atmosphere. Our anesthetic gases actually contribute significantly to that bucket of greenhouse gas emissions that come directly from the hospital. It's estimated to be about 20%, and it has been reported as high as 50% of Scope 1 emissions. And so what we wanted to do was we conducted a quality improvement initiative so that we can reduce emissions from anesthetic gases. So there are 2 anesthetic gases that have higher environmental footprint that we wanted to try to have an effect on. The first is desflurane, and that's because the global warming potential is about 2,500. So that means that it's 2,500 times more efficient at trapping heat than carbon dioxide. The other anesthetic that has a higher environmental impact is nitrous oxide. So while its global warming potential is closer to 300, the real problem with nitrous is its atmospheric lifetime is 117 years. That means that anything I turn on will still be present 100 years later. So part of our study was to raise awareness. We wanted to educate our providers about the environmental footprint of our gases. And on top of that, we wanted to see if we gave them strategies, if they would employ this to decrease their carbon footprint. So at the beginning, we educated our providers. And then the next step was we queried all the medical records and we sent out reports to our anesthesiologists on a monthly basis where they got their own report card of their carbon footprint from anesthetic gases compared to departmental averages. We also, we created this report where they had carbon dioxide equivalents, and then we tried to make it more relatable, and we converted this to miles of a car driven per anesthetic hour. So if you're driving 10 miles an hour for 8 hours, you're doing pretty well. Now, if you're driving 100 miles per hour for 8 hours, that's quite high, and you should probably slow down. So just for comparison, that would be driving 80 miles, so maybe to Long Island and back. The 800 miles, it would be driving from New York City to Chicago in one day. And so putting it into those terms, I think really affected our clinicians. And we were able to have a reduction across the board in most of our anesthetic. At the end of the study, the clinicians reduced their use of desflurane so much that we were able to completely remove it from formulary. So that means that they switched from desflurane, some of the users, to sevoflurane or isoflurane, which had a lower environmental footprint. In terms of nitrous oxide, that's a slightly different gas in a different animal. So it's a commonly used anesthetic. It's also known as laughing gas. I think people get it when they go to the dentist or their children get it when they go to the dentist for dental procedures. As I mentioned before, it has a very long atmospheric lifetime. Nitrous is very unique in its property because it's stored as a compressed liquid in these large tanks. And nitrous is then piped through usually a central supply into the operating room through a piping system, a very extensive piping system to our anesthesia machines in the OR. There have been recent reports that there's a tremendous amount of loss. So there's some loss from the pressure release valves from these large tanks, but also there are losses along the pipeline. So what we did was we looked at our annual purchasing data from nitrous, and we also looked at our clinical use. And when we compared the two, what we found was we had a 94 to 97% discrepancy at each of our campuses. That means that we only were using about 3 to 6% of our purchased nitrous clinically on our patients. After we came up with these data and we presented to our executive leadership, we decided to decommission nitrous. We've been able to get rid of a lot of the waste from our centralized nitrous system, and that's true for across the board at every campus that we have at this point. What we did in place of that is we attached smaller cylinders of compressed gas or liquid nitrous at the back of the anesthesia machine, and so our clinicians can still use it, but we eliminated a lot of the loss. The other thing that happened over the course of the year when we transitioned to the e-cylinders was that our clinicians decreased their clinical use by more than 70%. So we were able to achieve those results with our nitrous efforts. I think what we learned was when we put a barrier in front of someone that they're not going to go back to the anesthesia machine to open the tank unless they feel they really need it. And so that was also, I guess that's a little bit of behavior modification that happened as a consequence of switching over to the nitrous cylinders.
This is something that many healthcare systems are struggling with and many providers. How do you make sure that you're not sacrificing patient care when it comes to all of the changes that you're making in your practice? It's really important. Clinicians, one of the first questions they're going to ask about patient care. Hospital administrators and executives, what about patient care? Because patient care comes first for many healthcare providers, but talk about how you made sure that you were able to center patient care along with making all of these changes. It's not a unique challenge for Mount Sinai. I think this is a challenge that we've heard from many healthcare systems.
Absolutely. So it is a challenge. But as I said before, with the inhaled agents, we have alternatives that are equally safe. They've been around for many, many years, decades, if you will. And so they're equally effective alternatives. And in terms of nitrous, it wasn't that we were removing it entirely. What we did was we just transitioned the form that it's available in. Instead of having it through the central pipe system, now it's being directly connected to the back of the machines. And so the clinician has to go in the back of the machine to turn it on and open the valve, basically, to use it. But it's always there. And so if someone feels that this is important and a priority for the patient that they're taking care of, they can have access to it and they can just open it. Patient care always comes first. And we never want to compromise that, even with any of our initiatives.
I'm blown away with the information you shared about the amount of waste. I understood kind of coming into this discussion that there was waste. I didn't understand the scale. That has been just eye-opening. The example that you shared, only 3% of the piped nitric oxide that's a staggering number. So maybe you could talk a little bit more about what are other clinicians saying as you start to uncover these. This is a very big kind of wow realization, at least from my standpoint.
So yes, it is a big wow. And I think that it started out with a few reports back in 2022. And so I think this is actually becoming more common knowledge. And so a lot of other facilities are actually transitioning. I think it's a growing trend. And in fact, some hospitals now, that newer hospitals are being built because they know about this, are actually being built without central pipe nitrous. And they're actually saving millions of dollars in the construction process by not including it.
I want to go back to where you talk about hospital waste. I remember growing up and hearing about the 3 R's: reduce, reuse, recycle. Recycling is very visible and tangible. Reduction and reuse often provides a unique set of challenges. Tell us how you're approaching this at Mount Sinai.
You are absolutely right that recycling is highly visible. However, it's actually not the most impactful strategy. The EPA has a waste hierarchy, which is a inverted triangle. At the very top of this triangle is actually prevention and reduction. Then reuse follows, repurpose, and for us in healthcare, it's reprocess. Recycling comes after all of that. So it is not the most impactful thing that we do, but it is actually highly visible. And it's a way that our staff can engage. Only about 20% of waste is recycled. If we don't actually engage in recycling, we can't really do anything about that 20% of the waste. So Sinai does have a recycling program for that reason. But I see it as a way to start the conversation about reduction. It's more of a Band-Aid as opposed to a source. So what we really want to work on is source reduction. So we want to not have that piece of waste entering our waste streams in the first place. If we don't need it, we shouldn't be purchasing it. We shouldn't be opening it. And that's where we need to be working at.
This is another area that we're talking about when we're talking about the NYSIF pledge and leveraging the pledge. When people are having conversations inside their organizations, hospitals, healthcare, supply chain, not even bringing those purchases in is a savings up front off the cost of the waste. It is hard when things are highly visible like recycling, but backing up into that triangle is where we're going to see a lot of change that's made. But when something's not visible and tangible, we have to do a lot of education and communication around it.
What we're trying to do is reframe the conversation so that it's more about thoughtful resource utilization. There is a significant cost savings by not purchasing it in the first place, for not letting it enter into the health system in the first place.
What is that circular connection between climate change and patient care?
Healthcare shoulders the burden of caring for patients and individuals who are affected by climate change. But in the process, we're actually making the situation worse because you're contributing to greenhouse gas emissions. We know that carbon emissions are the main driver behind climate change. And climate change is linked to health conditions, worsening health conditions, including asthma exacerbations, changes in vector ecology, cardiovascular events, and heat-related illness. With climate change, we're seeing more frequent and more severe weather-related events. And that results directly in illness, death, displacement of entire communities. This is a public health crisis that we need to address. And in fact, the World Health Organization has stated that this is the biggest public health crisis of the 21st century.
Dr. Trinh, this has been such a fabulous conversation and dialogue. I think this is going to be impactful for all of our listeners. So thank you for the opportunity to share a little bit with us here for this discussion. Wanted to switch gears slightly. One of the things we like to do when we have the opportunity to have guests like yourself in with us is talk a little bit about them and some things that drives them. We frame this and we call it our fundamental questions. So one of the fundamental questions that we like to ask is maybe you can talk to our audience a little bit about who inspires you or what inspires you, the incredible work that you're doing. So a fundamental principle that guides you is kind of how we would frame it.
In terms of fundamental principle, I think as a physician, we've all taken the Hippocratic Oath, and that is first and foremost to do no harm. We're in the healthcare business, and so that means that healthcare's mission is to protect human health and improve human health. And so that's a fundamental that I truly do believe in, and I try to practice in my daily care.
What's your fundamental advice for other doctors and those serving in the public health sector that may want to do the work that you have done?
I think in terms of advising other clinicians and just people in general who are interested in this work, I think you should start small in something that you are passionate about, and you should work up with that. Like I said, I started off with recycling. It was not the most impactful thing that we could have done to reduce our carbon emission, but it was something. And eventually what it allowed me to do was meet other people that work in this space and allow me to collaborate and build other projects and also conduct research in this area.
Dr. Trinh, I'd love to know, you're a leader, but who's been a mentor to you? How did they inform who you are and how you lead today?
So I want to say that I've been very fortunate to have 3 mentors and sponsors who have not only shaped my career, but also the way I think and the way I lead. So the first is actually David Rich, who is the president of Mount Sinai Queens and Mount Sinai Hospital. He's also our chief clinical officer for our health system. Dr. Rich is both a mentor and a sponsor to me. He's helped guide me, and he's also given me opportunities to work in this space. And as you may know, he was the one who appointed me to be the medical director for sustainability. And in doing so, he gave me space to build something new. But in terms of what I admire about Dr. Rich, I think it is the fact that he sees possibility when people may see roadblocks. And what I've tried to do is I've tried to adopt this, because whenever I have a challenge or I reach an obstacle, as opposed to thinking of it as a stopping point, I think about it as a pausing point to think, and I want to understand the problem at hand. Because once we understand the problem, we can work with that and try to work around that. The reason why I think it's so important is because it's allowed me to think creatively and strategically, and that's important in a space where the path isn't defined. The other person that has been both a mentor and a sponsor is Dr. Meg Rosenblatt. She is the chairperson for anesthesia at Mount Sinai Morningside and Mount Sinai West. So Dr. Rosenblatt and I share a common vision and a common commitment to decarbonize healthcare. She has also opened many doors for me. But what I admire most about her is the way she celebrates the successes of people around her. So Dr. Rosenblatt truly finds joy and satisfaction when her mentees thrive and excel. And I really like that spirit of generosity. And that's something I want to adopt in my leadership. I want to build my team. I want to be positive with the people I work with, and that's how I intend to lead. And lastly, I would be remiss if I did not mention Dr. Andrew Lieberwitz, who is our system chair for the Department of Anesthesia. He has served as a phenomenal sponsor for me. He has paved the way, given me time, and sponsored my work in sustainability. Without his support, I would not be where I am now in the position that I am in now.
Dr. Trinh, thank you for your time today. Thank you for sharing about Mount Sinai and Mount Sinai's efforts. It has been a pleasure to have you.
Thank you so much for having me. It's been a pleasure speaking with both of you.
Thank you so much.
This is Fundamental, the podcast from NYSIF. If you want to take the pledge, businesses pledge to reduce greenhouse gas emissions, enhance the resilience against climate-related disruptions, and develop a climate action plan. businesses in the healthcare sector will receive an upfront premium credit of 5% up to $1 million per policy. Eligible organizations have 10 months after taking the pledge to develop and submit their climate action plan, giving them an ongoing premium credit of 5% up to $1 million per policy. The plan must include strategies for monitoring, measuring, and reducing emissions, and for improving resilience. Hospitals and other healthcare sector businesses have flexibility in choosing those strategies. NYSIF provides a learning forum to assist program participants with their climate action plans. Participants receive the premium credit each year as they continue demonstrating progress implementing their climate action plan. The ongoing credits are amplified when coupled with other available funding, and over time will help participants realize cost savings and leverage the pledge.